Good afternoon, everybody. In this session, we discuss vulnerable plaque and vulnerable plaque treatment. I'm here with my co-chair, Duk-Woo. My name is Evelyn Regar, and we have, as discussant, Dr. Jang, Dr. Akiko Maehara, and Dr. Kubo. Let me start by introducing the topic. What is a vulnerable plaque, Dr. Maehara? You showed that it is not one single entity, but that there is subtypes. Could you please summarize and educate us on vulnerable plaque? What is it we are looking for?
Sure. I think because we know thrombotic lesion, they looks quite different. And then 70% or 60% is about plaque rupture, 30% is plaque erosion, and 5% is calcified nodule. And if you look into the underlying plaque, it's very different. So I think the prediction of those events should be different. That's my opinion. So if you're looking for the lesion which causing the plaque rupture and thrombotic event, the appearance should be a lot of lipidic plaque and typically necrotic core, and surface is thin cap. And by pathology, they say more inflammation compared to plaque erosion. So those are the characteristics of the before rupture. So those I do think the high risk of vulnerable plaque to predict plaque rupture. That's number one. Number two is plaque erosion. And as we discussed, there is no clear plaque phenotype to predict plaque erosion. But some data suggest at least after the erosive thrombotic event, they have some typical very focal shear stress type or like very specific cohort. If the patient having the coronary spasm, when we do the OCT, we see like the thrombus, like the plaque erosion, or like the even there is no thrombus, looks like the old organized thrombus on top of the plaque. So I don't think that's explaining everything, but some of them could be due to those type of the pathophysiology behind. That's for the plaque erosion. But I think I would emphasize, majority we don't know yet what is really causing the plaque erosion plaque. And in terms of the calcified nodule, it's actually quite clear. When we look into the calcified nodule, it's very severe calcified. And when we look into the prospectively to look for, at the baseline, it's calcium, no calcified nodule, but follow-up, we see the calcified nodule, how it looks like the baseline characteristic. It's really large amount of the calcium, and typically the calcium seems to be a little bit immature, meaning we still see there's some lipidic portion inside of the calcium. That's one. And the other one is like many times we see the calcified nodule at the mid right coronary artery. Those are the leak hinge motion. Those are really the prediction of the calcified nodule. So I do think if we ask what is high risk plaque, to predict calcified nodule is those kind of characteristics.
Thank you very much. It seems that thin cap fibroateroma is the predominant plaque type, and it's the best defined. It becomes more elusive when we talk about erosion, because most of the time it's a diagnosis by absence. We see thrombosis on the vessel, but we don't see plaque or plaque rupture. And then there is this calcified nodule, which seems to be a rather rapid evolving entity, where the calcified nodule serves as a crystallization point for thrombosis. May I ask Dr. Kubo, how do we differentiate these plaque types with the different invasive imaging modalities, and how do you see their role?
So before the answer, so I have a question to the Dr. Akiko. So the Professor Maehara have a great experience, a lot of experience for the intravascular imaging for coronary atherosclerotic lesions. So we know that TIC4 is a precursor lesion of plaque rupture. I'm interested in the near future. So I would like to identify the precursor lesion of the plaque erosion. So do you have any idea the specific lesion characteristics for the precursor region of the erosion?
answer is no. We don't know well. But I think if we look into the bunch of the rupture cohort and the bunch of the erosion, typically the erosion region is less lipid and secure and relatively focal compared to the rupture. Those are what we see. But as we discussed, there is no clear, like the TIC4 type of the high risk part to predict the plaque erosion.
So, in this session, one presenter gave us a future imaging modalities in OCT NILAF, and it may be able to detect the macrophages accumulation more accurately. So, is it the potential to identify the lesion precursor from plaque erosion?
Oh, that's interesting question. I don't know, but I think that's all the whole question, which we don't know yet. But I think I agree. Like one of the people from Japan, when they look into the plaque erosion, they see macrophage more than adjacent segment. So that's possibly some sort of, I don't know that's the reason or that's the outcome yet.
Thank you so much.
So my question is Ik Jang, and Ik is absolutely father of OCT and the pioneer of OCT.
Grandfather.
So my question is, we have a very diverse intracoronary imaging tool, and many audience and many reader after the singing the PREVENT trial, which imaging modality is most predictive, is most precise for detection of the vulnerable plaque? Virtual histology, IBUS, NIRS, OCT. Some physician is criticized in the, even though high resolution IBUS cannot detect the vulnerable plaque, just assess plaque volume, not detect the vulnerable plaque. But what is the most predictive, what is the best intracoronary imaging method to assess vulnerable plaque?
So it comes back to the original question, what's the definition of vulnerable plaque? If you define vulnerable plaque as a plaque that is prone to progression, leading to supply-demand imbalance, then plaque burden, no question. And there were 3 or 4 predictors, and one is TIC4, and microvessels, and layer plaque. So TIC4, probably the mechanism for rapid progression is plaque disruption, rupture, mural thrombus, layer plaque, microvessels, possibly intraplaque hemorrhage. And layered plaque, as I mentioned briefly, so the main mechanism of plaque progression overall is continuous plaque disruption, healing, disruption, healing. And as I mentioned very briefly, when plaque gets disrupted, you have to deal with local and systemic thrombogenicity, right? And then everybody has defensive antithrombotic mechanism, primarily endothelial TPA and UPA. When this balance breaks, when thrombogenic stimulus outweighs the defense mechanism, then you may form an occlusive thrombus. But at the same time, what is important is residual plaque burden. As I showed in my slide, when lumen is, let's say, 2 millimeters square, you don't need much cells. You don't need many platelets to occlude it. Whereas the lumen is 6 millimeters square, then you need a lot of stuff, right? Fibrin, platelet. So I think plaque burden is key, critical factor to define plaque vulnerability. And if I can just add, plaque erosion, that's something, as you know, we've been studying for the past, over a decade. There are 5 predictors which you can use to narrow down patients with ACS for possible plaque erosion. And as Dr. Regar mentioned, erosion at the present time is a diagnosis of exclusion. So what you do is you look at the culprit lesion, and if you don't see plaque rupture and rarely calcified plaque, then you assume this is plaque erosion. Very suboptimal. So as you might know, we have developed a deep learning algorithm which will allow us to make a positive diagnosis. So it is easy to assume someone presenting with plaque erosion, he or she may have plaque erosion elsewhere, which is clinically silent. And we have not been able to make a diagnosis because of lack of diagnostic modality. Now we should be able to. Coming back to plaque erosion, I mentioned 5 predictors. One is younger age, absence of diabetes, and normal renal function, LAD, and hemoglobin level more than 15. They are not random. If you see young, no diabetes, normal renal function, low level of inflammation, right? LAD compared to circ or right, what's the difference? Many side branches, flow perturbation, flow patterns different, diagonal septal, right? And then finally, hemoglobin more than 15, high viscosity. That's directly related to computational flow dynamic changes. So it is not that simple. I try to emphasize, it is not the case that plaque rupture is all about inflammation. Plaque erosion is not. Plaque erosion has also certain level of vascular inflammation, but the level of inflammation is totally different. As I showed you with PCAD attenuation and so on.
Thank you. So, how do we proceed in the most practical way in searching or detecting vulnerable plaque? Do we go for non-invasive methods?
I think ultimately, yes.
Yes.
Yeah.
Could
So-
you elaborate for
Yes.
the audience?
So, vulnerable plaque detection is basically screening tool. So screening tool in my mind has to be simple, cheap, easy, non-invasive.
Yes.
And you cannot bring in someone walking on the street and come here, I will take a look
Absolutely.
at your coronary arteries.
Absolutely.
You are the OCT
Yeah,
lady, but
yeah.
you don't want to do that,
Yeah.
right?
Yeah.
Simple blood test will be good, but we don't have such a thing. So CT scan, I think, will be the next step, which will provide certainly plaque burden. And now they have a model which will show you the percentage of non-calcified plaque, low attenuation non-calcified plaque, and all that. Calcified plaque, as you know, may represent more stable advanced type atherosclerosis. And it will clearly show plaque burden. So as a first screening tool, other than general Framingham risk score and all those, in terms of diagnostic modality, I strongly believe it should be non-invasive.
Okay, so do you think we are there yet already with hypodense plaque, Nepkin sign, plaque burden? Is this enough?
No. So we need outcome data. And as
Okay.
I presented, we have compared those 4 high-risk plaque features on CTA using OCT as a gold standard. And they do correlate.
Yeah. After in the prevent trial is a few weeks ago, late-breaking trial ACC, immediate we have a press conference room interview with the reporter. There are general audience, not the physician. First question to us, how do you find patient with vulnerable plaque in your practice? It looks like simple. It's not simple for us. Is it Akiko and Kubo and Ik? How do you explain? Is it some general people ask you, how do you find the patient with vulnerable plaque in your practice? The outpatient or inpatient? How you gonna do?
So currently I use risk factors. There is something called ASCVD. So you just put all those data and it comes right. If the score is more than 5%, certainly more than 7.5% risk, 10 years, then we want to be aggressive in terms of risk management. We have published using proteomics data, analysis rather, to correlate with the plaque characteristics. We use TICFA as a sort of target, and there's something called calretinin, which is directly correlated with TICFA prevalence. And we also look at microbiome. So those are easy tests, right? You see a patient in clinic and you ask them to send the fecal samples and you do microbiome analysis. There are certain microbacteria gut, which has close correlation with high-risk plaque features. Both were published.
So is it Dr. Kubo and Akiko, in your practice, in your cath lab, which patients consider preventive PCI? Is it FFR negative patient? So can you?
So for us, we are very intravascular imaging frequent user. So not so difficult to perform the 3x3 imaging. So after PCI to LED, LCX or RC imaging, not so difficult issue. So generally, we see the intermediate region, we can perform the imaging, and also we perform the physiological assessment because it's covered by insurance. I think so detection of vulnerable plaque is very important. But on the other hand, current evidence showing us the negative predictive value of intravascular imaging is very high. So fibrotic plaque, calcified plaque, it's very low risk for the future event. So if we see the intermediate region angiographically, we perform the imaging, and if it is a fibrotic or fibrocalcific, we can leave it. But the lipidic or thin-cap fibrotrauma, we consider we should perform PCI or OMT. So we can use intravascular imaging for the deferral of the PCI to the non-cooperative intermediate region in our daily clinical practice.
Dr. Kubo,
Yes.
you published 75% of TICFA will stabilize become non-TICFA. You're the first author.
Yeah.
And now you are saying totally opposite thing.
Yeah.
Tell me.
Yeah. But so
What changed your mind?
No. I would like to say TICFA changed the T-cap fibrotrauma, and T-cap fibrotrauma changed the TICFA. So plaque dynamically changed the plaque phenotype in the short time. So baseline TICFA is not necessary to be the TICFA in 1 year, 2 years, 3 or 4 years. So a baseline TICFA is a high risk. But the baseline fibrotic plaque is a low risk for future becoming TICFA or future event.
Actually, we did the study 3 time point also, the baseline 6 months, 12 months.
Yeah.
And if you give, high intensity statin, they double the fibrous gap thickness in 6 months, and they triple in 1 year.
So my another question is about the vulnerable plaque medical treatment in the contemporary practice. We know just some antiplatelet therapy and the repeat rolling agent. Some new drug is under investigation, like a lipoprotein A rolling agent or interleukin-6 antagonist by Novo Nordisk, and GLT is targeting anti-inflammatory mechanism. Is Akiko and the Ik and is Evelyn? Do you think that is anti-inflammatory working agent can modulate the fate of a vulnerable plaque? How do you expect?
Of course. I really think so. Yeah.
Good. We have a lot of much.
We
OMT.
started using colchicine
Yeah.
more and more is approved. There was a study to look at the plaque changes.
Is there any dramatic change after using colchicine?
I was asked to review, so I cannot disclose.
Okay.
So people are looking at it. IL-6.
Yes, good. Wow. So and now is IL-6 and the the LPA rolling is a huge trial is ongoing. It's mainly targeting documented ASCVD, also combining some traditional risk factor, diabetic and blah blah. And the 2 or 3 years later, we will have a much, the powerful OMT drug. Yes.
So to me, let me put the question differently. Is it already clear that inflammation is a trigger and a cause of rupture, or is it a bystander? Do we have enough data
I would say it's the main contributor.
to be okay?
From
not,
every,
not only the rupture, for the progression of the atherosclerosis. That should be the main contributor, I think, too.
a progression might be due to silent plaque rupture.
Yeah.
So it's not associated, but it's a causal contributor. Is that what we?
I think so.
I'm not sure. Because we don't have potent, effective anti-inflammatory agent. So if we were to have it, then we treat it and see the evolution of plaque phenotype. We don't have the data yet.
At least the trials with dexamethasone and so on did not
No,
show
those
the
didn't show
effect.
anything, but
So
it's not really ideal.
it's not ideal. It's true.
Okay, and I think the time is already done, and this year is a vulnerable plaque. Over the last 20 years, vulnerable plaque always a hot debate And this year, much debate,
Even more
and the
so.
next year would be much debate. I think this interview session would be very helpful to interventional community audience. And thank you, is everyone, and it's very nice talk. Thank you.
Thank you so
you.
much.